All right. Good morning, everyone. Good morning and welcome to Free Webinar Wednesday with Archer Review. My name is Lexie and I'm going to be the Archer Review tutor that's hanging out with you folks today as we go through some basic care and comfort type questions to get you ready to take and then pass your NCLEX attempt. Now, before we jump into all of the meat and potatoes of today, I want to give you a little bit of background about me. So like I said, my name's Lexie. I am a registered nurse, and I've been a registered nurse since the end of 2011. I've been a med-surg nurse. I've spent time in the emergency department, quite a bit of time in the emergency department, actually. I'm a certified emergency nurse. I've worked in COVID vaccine clinics. I've been a travel nurse. I've kind of done a little bit of everything, really. So today, I am so excited to hang out with you folks. And while we are hanging out and going through these kind of practice questions, we are going to utilize a tool called Slido. So in a moment, when I change my slides here, you're going to be able to join into this session with me because we've got folks streaming from GoToWebinar. We've got folks on Facebook. We've also got folks joining us on YouTube. So we're all across a whole host of platforms this morning. Slido is going to be a great place for all of us to interact together as one. So we're not jumping from platform to platform to platform. Now, if you folks do have questions while we go through today's webinar, please reach out in the chat though, because we do have other Archer Review tutors hanging out in those chat platforms. So we've got somebody on YouTube, somebody on Facebook, and on our GoToWebinar as well. So before we even get into that Slido slide, I promise it's coming. A little bit more just about basic care and comfort. So if you're somebody that's out there kind of like scratching your head, like basic care and comfort, what does that mean? So remember, the NCLEX exam is kind of broken up into 8 core test plan areas, and basic care and comfort is one of those 8 core areas of the exam. So when you get to your NCLEX and you get a basic care and comfort type question, this may be a question that has to deal with hygiene and personal care, maybe mobility and immobility, nutrition and oral hydration, elimination, non-pharmacological comfort measures. We've got rest and sleep, the use of assistive devices, and alternative and complementary therapies. Now, that list that I just gave you folks, that's not the entire list, but those are the big concepts that show up under those basic care and comfort type questions. And so that means those are the kinds of things that we are going to practice here together. So folks, I'm really curious, where are you all joining me from? And here's that Slido slide that I mentioned. So to join Slido, all I need you to do is point your camera at that QR code and join on into our session. I'll give everybody a few moments to get logged in. Now, if you don't have a cell phone, or maybe you're actually watching me from your cell phone, if you have access to an internet browser, you can join us at slido.com and then just use that hashtag basic care and comfort to join into today's session. So as we get going here today, folks, where are you all joining me from? I'm curious. I'm in the Southern California part of the United States. Ooh, we've got somebody joining us from Maryland. Good morning, good morning. Where else? Let's see here. California, Toronto, awesome. Florence, Kentucky. Nepal, greetings from Nepal, the Philippines. Ooh, we've got folks joining us from all over the globe this morning. Canada, ooh, and Canada's nice and big. Ooh, Philippines means got a couple people joining us from the Philippines. The larger these words show up, the more people we have joining us from that area. That Slido code is right there on the slide there for you, that QR code. And once you log in, if you can't use the QR code, if you head over to slido.com, once it asks for the name of the session, just go ahead and put in basic care and comfort. Okay, so we've got quite a couple people here this morning joining us from the Philippines and Canada. Well, greetings. We got a couple folks from Sri Lanka. We've got Delaware, Nebraska. Good morning to all of you. Well, let's get into it. Let's just do some practice sort of questions together. And don't put that phone away because we are going to use Slido as I show you these practice questions. So when I show you these questions, just go ahead, keep that phone handy so that you can answer and give me whatever you think the correct answer might be. All right, well, let's get to it. Let's start by just talking about some basics. Got some real easy, I think, warm-up type questions here for us this morning as we practice some of our basic care and comfort type questions. So to start with, what is a normal range for adult body temperature in Fahrenheit? And if you can only give me Celsius, I'll take Celsius too. But what do we think that normal range is? All right, we've got one here in the Slido box, 97.3 to 98.9. Oh, I like that one. We've got somebody who gave me their answer in Celsius, 36.5 to 37.5. Got a couple more people typing. I don't want to cut anybody off. Let's see here. Let's see. You guys are really all on top of it. Absolutely. Now, on the NCLEX exam, they're going to give you both Fahrenheit and Celsius. So let's take a look. What is the technical answer that we've got? So our range for a normal body temperature in an adult is going to be 97.8 Fahrenheit to 99.1, which is 36.5 to 37.3 degrees Celsius. Nice job, you guys. All right. So here's our next one. What's the correct site for measuring a patient's pulse rate? And let me specify an adult patient. Where is the correct site for measuring an adult patient's pulse? What do we think? Where's that site? If you go into your patient's room and you're wondering, what's their actual pulse? Where are you going to actually put your hands on your patient? Absolutely, you guys. Everybody who's telling me radial, that site right here in my wrist, my radial artery, absolutely. So when you're just going on up, assessing our patient, absolutely. Now, I do like how you folks, though, mentioned carotid. Now, whoever in that Slido chat mentioned carotid for CPR, yes, you're absolutely right. If we find an unresponsive patient, we're going to feel for the pulse in their neck. But generally speaking, when we're just assessing our regular run-of-the-mill patient, absolutely, we are going to be assessing that radial artery. Nice job, you guys. Well done. Well done. All right, here's another one here for you. What does that top number, the systolic number, represent in a blood pressure reading? How would you explain a systolic blood pressure to me? And so 120 is a good reading, but what is it representing? How would you explain it? I know nothing about blood pressure, nothing. I just landed on Earth. How would you explain systolic blood pressure to me? Given a few more moments here, because I know it takes a couple seconds to answer on these Slido questions. Yeah, I like those answers that are populating up here on the Slido slide. That atrial contraction when the heart pumps, absolutely. So when we look at somebody's blood pressure, right, we get those two readings. That first reading, when our atria contract, actually when we just sort of have that pressure present in our circulation. Because then our heart relaxes, right? We squeeze, we relax. We squeeze, we relax. And that's why we get those two readings. We get the systolic blood pressure, which is when our heart contracts. Then that diastolic number, that bottom number, is when our heart relaxes. And that's why it's a little bit lower. See, when our heart contracts, obviously there's a lot of pressure in our circulation to get that blood all the way out to the farthest away spots, right? When our heart pumps, we need that blood to go all the way on out to our fingers, to our important organs. But when we then pause or relax, we don't lose all of the pressure. That wouldn't make sense. And that's why that diastolic pressure then is a lot lower than the systolic. When we squeeze, we relax, but That's why when we look at somebody's blood pressure, we shouldn't just automatically look at that top number, that systolic number, right? We want to make sure it's not too high, but we should also be keeping tabs on that diastolic number as well, because, well, if it's too high when somebody's heart is relaxed, ooh, we may need to get them on some medications or make some lifestyle modifications. Well done, you guys. Absolutely. It's the pressure in the arteries when that heart beats or contracts. All right, all right. Let's take a look at another practice question here. Let's do this one. I want you folks to name me 2 factors that can affect a patient's blood pressure. Any two that immediately pop into your head. Give me something. And we'll see what the most popular answers end up being here. Let's see here. There's a couple that are showing up as I scroll through. The ones that I see most often here, that's stress, absolutely, and lifestyle. That's very, very interesting. Absolutely. Ooh, bigger cuff taken. Ooh, absolutely. If we have a poorly fitting cuff on our patient, it may not give us the right reading. Good point to make there. But let's see here. What can ultimately affect a patient's blood pressure? Well, the things that really come into my head is the one that I see most often here. Stress. Absolutely. The more stressed out we are, the more our blood vessels clamp down. The more vasoconstriction that we have, the higher our blood pressure is. And so as our vessels are clamped down and all that blood is pumping against them, it can really wreak havoc on those vessels. And if we think about it, all those vessels ultimately are supplying blood to those really important parts of our body, our kidney, our heart, our lungs. So it can easily and very quickly lead to damage of those vessels. So absolutely stress. Another one, age. Absolutely. Our blood pressure is going to be a little bit higher as we age. Obesity can affect a patient's blood pressure. Medications can definitely affect a patient's blood pressure. Now, meds can affect us in both ways, right? We put patients on ACE inhibitors. We put patients on beta blockers. We put patients on our angiotensin receptor blockers. We put patients on vasodilating medications. We put patients on calcium channel blockers. Those are the big 5 classes of medications that we use to manage blood pressure. Now, those medications lower a patient's blood pressure, right? But there's other medications out there that we also have to be careful for because, well, they can raise a patient's blood pressure, and we don't necessarily want that happening either. So absolutely, medications can affect our patients. Their activity level can definitely affect our patient's blood pressure. Now, I'm not sure if I saw it. I'm going to scroll one more time. Ooh, there it is, diet. Absolutely. A patient who has a very poor diet or maybe a diet very high in sodium might have an elevated blood pressure. So well done, you guys. You guys all got the really big ones. All right. Let's kind of change gears. I mentioned hygiene and skin integrity. So one of the other things that I think about when I think of basic care and comfort type questions on the NCLEX exam, really kind of those ADL type questions, you know, those activities of daily living, walking around, eating, bathing, being nice and clean, all of those facets that go into our regular nursing care. And I think sometimes we forget about that, the importance of these ideas when it comes to the NCLEX exam. All right, so let's take a look at this question. How would you answer this one for me? So what's the purpose of pericare for a bedridden patient? What do you think? Why do we do pericare? Why is pericare so gosh darn important? Because it is. Why? What's the purpose of it? Yeah, let's see here. We've got avoid infection, preventing infection, avoid UTI, prevent UTI. Ooh, all right. So those of you telling me pressure injuries, I like where your head is at. Hold tight, because I think that's going to come in a couple slides from now. Wink, wink. So let's talk specifically about the actual, pericare, cleaning our patient's genitals. So what is the purpose of it? Why is it so important? Well, really, if you are laying in bed and you were unable to bathe yourself, you'd probably start feeling a little funky pretty quickly, right? We generally shower every day, every other day. Why do we do that? Why do we bathe? Well, really, to control infection. You guys are absolutely right. We want to maintain our patient's cleanliness and to prevent infection in that genital slash perianal area. We absolutely just want to make sure our patient doesn't get any kind of funky infection. And really, folks, here's the other thing. When we take really good care of our genitals, of our patient's genitals, that our peri area, we need to get rid of that skin flora that's not great for us. The longer we sit with kind of dirtiness on our body, the more likely, like you guys said, we're going to have infections elsewhere. So let's say we have an infection in our genitals. Well, if we don't keep ourselves clean, if we don't keep our patients clean, that bacteria can end up getting on all other parts of the body and can lead to infections elsewhere. So you guys are absolutely right. Well done. Say, if you're somebody that needs a little bit extra help, just a little bit extra TLC, getting ready for your NCLEX exam, take a look at this slide that I have right here for you folks. This slide, if you open this QR code, now a different one than the Slido QR code, if you open this code, it's going to take you to the booking page to our private tutors. We have a whole host of amazing nurses who would love to work with you and get you NCLEX ready. Now, our tutors here, they want to work with you one-on-one to help you figure out what your weak areas are, to help you figure out an individualized study plan, to go over those concepts that are just still giving you the runaround. Maybe you were like me when I was in nursing school. Gosh, I struggled so much with endocrine, and now it's one of my very favorite areas. And I bet it's because I had to spend that extra little bit of time learning about that endocrine system. So we've got Allie. Allie is awesome. We've got Emma, we've got Lauren, Kate, we've got Jennifer, we've got Elizabeth, and we've got Megan. So all of these tutors here have open sessions throughout the month. If you are interested in booking with one of our awesome tutors, go ahead, open up that code. And when you do book, when you open up that code, it'll take you to our booking page. And each one of these one-on-one sessions, again, this is just you and the tutor, totally private for that hour, is $75 an hour. Now, if that's a little too expensive for you, hold tight. I've got another option we can talk about in a little bit here. But let's keep going here. I'm having too much fun with you guys. All right. So moving back on to hygiene, let's take a look at this question. So what type of bathing technique is recommended for a patient with a localized skin infection? So what kind of bath do you want to do for this patient of ours that may have some type of infection? All right, let's see here. Absolutely. So that sponge bath, yeah, the term that I think we more so are familiar with is a partial bed bath or a localized bed bath. But whoever said CHG, you are on top of it. That's one of our very specific cleansers that we use when we are doing a bed bath. Absolutely. Yeah, a local bath. You're exactly right. We don't want to necessarily, totally fully submerge them, do everything. We're just going to do a partial bath for those patients. Well done, you guys. Absolutely. And really, don't overthink these questions. I think that's maybe a little nugget of advice with these basic care and comfort type questions. Remember, basic care way back in the day. Let's remember Florence Nightingale, right? Way back in the day with the Crimean War, what was all of like her ideas behind nursing? Really keeping a patient comfortable, clean linens, cleaning the wound, and fresh air. The absolute basics. And guess what? It hasn't really changed all that much either. We still have to go back to the basics. All right, now for you rock stars that already kind of answered this question. How would you prevent pressure ulcers in a bedridden patient? So what do we do? What are some interventions we can do to prevent bed ulcers? All right. All right. I like this one. The first couple answers here in the Slido slide really all have to do with positioning and repositioning our patients. Absolutely. Right. If our patients can't reposition themselves, we need to reposition them at minimum every 2 hours. Yes. Now, can you move a patient more than that? Of course, but bare minimum standard of care is repositioning those patients every 2 hours. Let's think about that, right? Let's say we are sitting somewhere. We've been sitting, if you were hanging out with me for this whole hour, maybe at the end of the hour, you're all antsy and you got to get up because you just have been sitting for too long. Now you can do that. You can get up, you can move yourself. But what about that bedridden patient that's just really uncomfortable from being in the bed from hours on end, right? I know how excited I am when it's time for me to go to bed every night and rest. But if I was going to lay in bed all day, gosh, I would be so bored. And two, at the end of that day, just a full day in bed, I almost feel sore. So it's really important that we reposition our patients to prevent the skin breakdown on those bony areas. Yes, but all those other ideas, keep that skin dry and clean. Yes. When we have wet skin, think about if you've ever walked around in wet shoes and wet socks. Oh, yuck. If you've ever walked around and had wet shoes and at the end of the day you took those shoes off, you took your socks off, your feet were probably a little pale and wrinkly and your skin just looks so yucky. Now think about that. What if we've got a patient sitting in a wet incontinence brief? Oh, yikes. Their whole peri area is then going to break down and it can lead to our patient getting then contact dermatitis down there in their peri area. Use a specialty mattress, absolutely. Some other things I don't think we necessarily mentioned here. What about nutrition? Right, our patient that's laying in bed, if they're bed bound, I really want to make sure that I am working on the best nutrition possible for those patients, right? I want to make sure they're getting plenty of protein, plenty of calories. I want to make sure that they are getting those nutrients that they need so they can get better for whatever reason they're bedbound. And if they have wounds, anything like that, yes, proper hydration. We want to make sure they're well hydrated. Wrinkle-free bed, absolutely. Who likes laying on a big wrinkle in the bed? And that barrier cream, I like that as well. If we are worried about a patient that's incontinent, I absolutely want to put down a barrier cream to prevent any other moisture from getting back into their skin. That shouldn't be there. Moisturized skin is good, but skin that's too wet, not good. Awesome job, you guys. You guys got that one. Absolutely. Okay. All right. Let's try another one here. All right. Now, give me 2 complications that can arise from poor oral hygiene in hospital patients. What do you guys think? So when I think of oral hygiene in hospitalized patients, I'm really thinking about patients that are maybe ventilated, have a breathing tube in place. They can't do their oral care. We have to do it for them. Why do we do oral care for patients? Why do we do oral care for patients that are in the ICU and have a breathing tube? Why? What's the why behind it? What are we trying to prevent? Ooh, we got a good one in that Slido slide. All right. So you guys are really, you've gotten the big ones. The big one that I think that I get worried about, pneumonia. Absolutely. I don't want my patient getting pneumonia, especially when we have a patient that has that endotracheal tube or a trach, some type of airway support. More so an endotracheal tube, because if somebody has a trach, we can still do oral care on them a little bit easier. But if we have a patient that has a breathing tube in place, I know I have to do really excellent oral care because I want to prevent VAP, ventilator acquired pneumonia. Now, besides ammonia, absolutely, those mouth sores. I don't want my patient developing any sort of mouth ulcers. I also don't want my patient getting any cavities on my watch. I want to try to prevent any sort of dental caries from developing in my patient's teeth. So the big ones that I think of, those dental caries, aspiration pneumonia. But if you were somebody that told me mouth sores, yeah, those mouth sores can easily lead to further oral infections or oral thrush. Absolutely. You guys are on top of this basic care and comfort this morning. I'm impressed. All right, you guys, let's try another one. So when we do wound care, when we clean a wound, what are some things we need to think about? What's the correct procedure when we do clean a wound of our patients? Kind of playing a modified version of Jeopardy here this morning with you folks. Ooh, I love all of these ideas that are popping up. So aseptic technique. Yeah, we want to try to be as clean as we possibly can. Avoid cross-contamination. Ooh, that inner to outer. That's exactly what I was looking for. We always want to clean from that center part of the wound outward, and we're going to use some type of sterile saline or wound cleanser. You guys are absolutely right. So we're going to go from that center part on out. I always think of the dirtiest area to the cleanest in a way, right? When I think of how we do Foley catheter care, right? When we do Foley care, we're going to hold that catheter at that insertion site and go away from our patient. Same thing with our patient's wounds. We're going to move away from that center part of the wound. Absolutely, you guys, you got it. And each patient's going to have different patient care orders. Sometimes we just have to use sterile saline. Other times we may use a wound cleanser. It's going to depend on your patient care orders, the facility that you're working at. So those things will come into play. But for the NCLEX, we're going to start from that center and move on outward. All right, so I mentioned mobility and immobility. So again, sort of shifting gears here under that basic care and comfort umbrella. All right, so I know we already kind of answered this question, but I'm going to ask it again. And the reason I'm asking it again, wink, wink, nudge, nudge, these ideas show up most often on the NCLEX exam. Why is turning and repositioning so important for our immobilized patients? Now, we talked about what we can do, but why is it so important? Why do we need to turn and reposition these patients? All right. So the big one that we already kind of covered, those pressure ulcers. When patients get admitted to the hospital, we have to make sure that we need to do a really good skin check, because if somebody got admitted to the hospital, came into the hospital, and they had a pressure ulcer from home, we're still going to take care of it, but at least then it's not on us. We don't take ownership for the creation of that pressure sore, that pressure ulcer, that bed sore, all those same names for the same idea. Yeah. Now, if somebody's hanging out in the hospital for a while, if we haven't been repositioning them and now they have skin breakdown, yikes, that's on us, the hospital staff, that let that occur. So absolutely, that's the big one. When I think repositioning, I think that prevention of bed sores. But I love that other point here that you guys are making, that circulation. Absolutely. When our patients are laying in bed, they have their blood isn't pumping as well through their body as it is if they're up and moving, walking around. We want to promote circulation, absolutely, because what happens if somebody has blood that's pooling in one area? They're going to be more likely to develop a DVT. So we want to make sure that we are moving our patients. That pneumonia is another big one too. When our patients are bedbound, we're going to work on coughing and deep breathing exercises, that incentive spirometer. Absolutely, that atelectasis, circulation, you guys got it. Awesome. The big ones, prevent those pressure ulcers and to promote our circulation. All right, now, I think I kind of answered one of these already by what I mentioned in that previous slide, but what are some complications now of immobility in our elderly patients? And yes, we know pressure ulcers. Besides those pressure ulcers, what else you got for me? When somebody's not moving, I think it's safe to say we all get worried about those pressure ulcers. But besides those, what else? All right. Ooh, contractures. Good on you for that one. Yes. DVTs, pneumonia. Absolutely. When we have patients that are laying in bed, not using their muscles, I'm going to get worried about that muscle atrophy or contractures. Now, contractures are permanent shortening and tightening of the muscle. And once a contracture happens, we can't really come back from it. So it's going to be very important that we try to mobilize our patients as early as possible. Folks, I saw something wild on YouTube the other night. I saw a YouTube of a patient in the ICU that was hooked up to an ECMO device. you know, the heart-lung bypass machine, the ECMO machine, up and walking around in an ICU. The benefits of early mobility right there for you. Mind-blowing, right? Wow, we do a lot of stuff now these days. Care has definitely changed than it did 20 years ago. So the big ones here, muscle atrophy, deep vein thrombosis, pneumonia, and pressure ulcers. Absolutely, you guys. All right, let's do another one. Now, I want you to explain to me how we would move a patient using a mechanical lift to transfer a patient from bed to wheelchair. What are the big steps you are thinking about right now in your head when you need to transfer that patient? We can easily see questions about transfer or safe mobility on the NCLEX exam. Ooh, I like that two-person assist. We should never operate a lift by ourselves. Well done. What else you got for me? Okay. All right, so if we're moving a patient from the bed to a wheelchair and we're gonna use a lift, yeah, we're gonna use that Hoyer lift, absolutely. So we're gonna need another person. Never, ever, 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 ever use a lift by yourself. Get some help. So, oh, I love that. I love that. Make sure those wheels are locked. Absolutely. So when we use a lift to move a patient, ooh, check pain status. I like that. You guys are good. So when we use a lift, we got to get that sling under our patient first, right? We can't just lift a patient up without anything underneath them. So we're going to tuck that sling underneath them. And this is really going to be helpful when you have another partner, another coworker in the room with you to help roll that patient. I love those proper body mechanics idea you guys are telling me in the Slido chat. Absolutely. So we're going to roll our patient. We're going to get that sling underneath them. Then from there, you're going to attach the sling to the lift per your facility's protocol, depending on the lift that you're using. And then I love that. Have your patient cross their hands over their chest if they're able to. Let's say our patient can't move themselves. It happens, right? We take care of stroke patients. We take care of paralyzed patients, but we want to do everything we can to tuck their arms in because we don't want that arm flopping on out to the side and then run the risk of harming our patient. So we're going to get them all nice and safe in that sling. We will then start to lift up. From there, you don't really want to have to move around a whole lot. So you already want to have that wheelchair right there next to you in the room. You'll raise your patient up from the bed. You'll move the entire lift on over, or if it's a ceiling lift, you can help direct your patient, put them in the wheelchair, slowly lower them down. And always please make sure those wheels are locked. When you're getting your patient onto the lift, make sure the wheels of the lift are locked. If you need to move the lift, unlock those wheels, get them centered in front of that wheelchair, lock those wheels again, and make sure those wheels on the wheelchair are locked as well. Awesome job, you guys. All right, now, how can we promote joint mobility in a patient that has been bedridden for an extended period? What are some things we can do for them? Yeah. Ooh, I love that word passive. Whoever said passive, absolutely. Now, right now, if I make a decision, right, to move my arm above my head, that's active. I'm actively making this decision to move my shoulder joint. But if I'm bedridden, maybe I'm sedated with a breathing tube in place. Maybe I'm recovering for an extended period of time and I'm sedated and I'm just having a hard time really moving my joints. If somebody else helps me and they slowly take my joints through their range of motion, we call that passive. So yes, passive range of motion, that's awesome. That patient that's been bed bound for an extended period of time, they're probably going to have weaker muscles. They're going to have a hard time moving all of those joints. So yes, passive range of motion. That turning and repositioning, flexion and extension exercises. Good point right there. And I would kind of then lump that in with the idea of physical therapy. Now, us as nurses, right? Us as the caregivers in the room constantly, when we get a patient ready, when we go check on them, we can do plenty of range of motion exercises. But it's also not a bad idea to get other people in the healthcare team involved as well. Our patient that's bedbound doesn't mean they can't participate in physical therapy. Maybe we need a PT consult for this patient. Maybe that's something we need to bring up at rounds whenever you have rounds on your patient, to bring up what other sort of team cares this patient may need. Well done. Awesome. Physiotherapy. Way to go. Yeah, absolutely. Physiotherapy, physical therapy. You got it. All right. So how about this one? This question loves to show up on the NCLEX exam. Explain to me the importance or why we need to use a trochanter roll for a patient with a hip fracture. Why do we need to do that? All right, so the trochanter roll. So the trochanter, that's like that head of our femur, and our femur is the longest bone in our body. Oh, I love that idea, that rotation idea. So if we have a patient that has a hip fracture, why do we most of the time roll up a towel? That's what we most of the time do in the hospital, or we use a pillow. Why do we do that? Why do we shove that rolled up pillow right against their femur? Well, those of you telling me anything about location or proper alignment, yes, we need to use that trochanter roll to help keep that proper alignment of the hip. We don't want that external rotation of the affected leg. Folks, most of the time when we lay in bed, right, if you think about when you were laying in bed last night, your legs kind of flopped out a little bit to the side. We always have a little bit of external rotation. Some people really externally rotate their legs when they sleep, almost like frog legs. I know I do. It's a weird thing. We don't want that to happen, especially in a patient that has a hip fracture. We want to maintain as much of our proper alignment as possible while that hip fracture is healing. And so that's why we put that roll just up against their femur to help keep it nice and in anatomical alignment. All right, let's move on to some non-pharmacological pain management ideas. What's the difference between acute and chronic pain? How would you describe the differences there for me? Giving folks just a few moments to answer here. All right, I'm loving these answers. Acute is short, chronic is long term. Yeah, when we really kind of just simplify it down, that's right. So when I think of acute pain is our short term and often has a specific cause, right? Let's say I had a wisdom tooth taken out. Oh boy, right? My wisdom tooth gets taken out. Maybe I've got some sutures back there, some swelling. Maybe I've got pain for a week or two. But then as that heals up, guess what? My pain goes away. So that would be acute pain. Now, what if I have not been taking care of myself and stretching properly after I've gone for a run my entire lifetime? What if I'm really bad at stretching and now I have really bad sciatic pain that happens just about every time I get in the car and start driving? Well, that would be more chronic pain. The chronic pain is pain that persists over a long period of time. Absolutely. That acute pain is normally pretty self-limiting. Let's say a patient fell down, broke their arm. Well, they're probably going to have some pain from that broken bone. That's their acute pain. But now let's say that same person who broke their arm still has pain years down the road. Maybe they had some nerve involvement. If they still have that pain that persists beyond that time that fracture healed, we would then consider that chronic pain. Awesome. All right. Well, because we're talking about non-pharmacological pain interventions, can you name me some? Can you name me 3 non-pharmacological interventions that we can utilize to help provide some pain relief for our patients? What do you guys got for me? I love this. Awesome. Diversion therapy, relaxation, deep breathing exercises, guided imagery, music therapy. Love those ideas. Ooh, acupuncture, acupressure, heat and cold. Absolutely. Really, anything I think we can do to get their mind off of the pain. Absolutely. So relaxation techniques, distraction, massage, heat and cold therapy, guided imagery. This is also where sometimes those complementary and alternative therapies come into play. Things like Reiki, biofeedback, acupuncture, acupressure. Ooh, yoga. I love that idea as well. Awesome job, you guys. Because remember, if a patient tells us they're in pain, we shouldn't just automatically think, all right, what med can I give you? No, we want to think about caring for the patient as a whole, not just throwing medications their way. So well done, you guys. Absolutely, absolutely. Okay. All right. Now, how would you assess pain in a nonverbal patient, such as an infant, or maybe somebody with severe dementia? What are some tools we can utilize? Possibly the Wong-Baker. Now, the Wong-Baker scale, those are the faces scale, right? The really sad one to the really happy, that whole continuum there. Wong-Baker faces, they're a great scale to use. They're more so going to be used for our patients that can't quantify pain, right? I can't tell my 5-year-old nephew, hey, Jack, your pain, 0 to 10, what are you at? He'll kind of scratch his head and tell me, I don't know, Aunt Lex. But now if I give him the images of those faces and I ask him, which one do you feel like he can point? So somebody who's nonverbal, like an infant or somebody with severe dementia, yes, we can do other scales. That FLAC scale, we can look how we're going to observe their behavioral cues. Are they grimacing? Are they moaning? Are they guarding? Are they grunting? Absolutely. Now, besides the facial expressions, I'm scrolling through here, scrolling. I don't think anybody popped this one into the Slido chat. What about vital sign changes? Can we ever see vital sign changes in a patient that's in pain? When I think of pain, I think tachycardia, maybe sweating. I may also think their blood pressure increases as well. So we can possibly even see some vital sign changes as well. But the crying, that's really what I would expect to hear in an infant, and really that high pitched kind of cry if somebody is in pain. Ooh, restlessness. That's another good one as well. If somebody keeps moving around, I can't get them settled in bed. Well, when was the last time we did something to help them be a little bit more comfortable? Absolutely, you guys, you got it. All right. Now, what is the idea behind the analgesic ladder, and how is it used for pain management? So when you guys hear that term, what do you think of analgesic ladder? And folks, when they give you words like this, use what you really think. Like when I hear ladder, I'm climbing, I'm moving up. So analgesic ladder, what is that really kind of getting towards? What is that pointing us towards? So I like that idea, that word hierarchy that just popped into the Slido chat. So the analgesic ladder, right? When somebody is in pain, do I immediately start with giving them the big gun medications, hydromorphone, fentanyl, morphine, oxycodone? Am I going to jump to giving them those kind of drugs? We're always going to go from the least invasive to most invasive. So this also lends itself to the idea of pain management. When we have a patient that's in pain, why do we want to start with our non-pharmacological pain interventions first? Because if repositioning, getting them a hot pack, a cold pack is going to make them feel better, do I have to give meds? No, not if they feel better. So let's start low. Let's go least invasive and make our way on up. Now, if our non-pharmacological pain interventions didn't really help, sure, let's think about adding a medication on in. But when we do think about adding medications on in, we would start with our non-opioid and then go on up to our opioids. So we always want to start from the least invasive measure and move our way on up. All right. Now, let's say you're somebody that is looking for a little bit extra help, but you don't really want to do that one-on-one tutoring. Let's say you're somebody that's struggling with endocrine, or maybe you're somebody that's struggling with EKGs. Heck, maybe you just want to work on some select all that apply questions. What I would encourage you to do is scan this QR code right now. So I'm just going to pause here for a couple seconds. If you open up this next QR code, this is going to take you to our booking page for our small group tutors. A lot of our private tutors that I mentioned on that previous slide do small groups as well. Lauren does a bunch of small groups, and Lauren really runs a lot of sessions in the evening. Now, I know those of you in the Philippines and those of you who were joining from all over the globe, it all kind of varies, right? Because we're all in different time zones. Generally speaking, Lauren has evening sessions, and by evening, I mean evening here in the United States. So either Eastern time, Central time, those evening times. Kate, she's also an ER nurse. She does a lot of cardiac-based small group sessions. So if you're somebody that's looking just for a little bit extra help, go ahead, scan that code. And these sessions are a little bit more affordable. These ones come in at $25 an hour, and they're capped off. There's a maximum of 15 students in these small groups, which means if you have questions, you can pop them into the chat. These sessions are going to, you'll sign up for them. It'll be run in a platform right now, in our GoToWebinar platform, and you'll be able to join, you'll be able to ask questions. All of the things you can do with a private tutor just won't be as focused, and it will have a specialized content that you will go through. So like I said, take a look at that QR code, see if any of those small groups interest you. All right, let's get back to a couple more practice questions here for today. So nutrition and elimination, another one of those big bullet points of ideas that can show up under this basic care and comfort umbrella on the exam. So right now, what is dysphagia? How would you explain dysphagia, and how would you assist a patient with it during mealtime? So it's kind of a twofold question. What's dysphagia, and how would you help a patient that has dysphagia? All right, absolutely. It's that difficulty swallowing. Okay, so we got difficulty in swallowing. Now, how would we help a patient that has dysphagia? Let's say you're taking care of a patient. Let's say they had a stroke. You know they're having a hard time swallowing. What are we going to do now? Right? We can't just starve the patient. What are we going to do? I love these ideas. So first of all, I love that idea of putting that patient nice and high in the bed. Should we ever be laying down when we eat? No, never. We should always be as upright as possible. So let's start there. Cool. So we're going to get our patient up to a high position. And from there, I am going to want to figure out what is the best consistency. Now, folks, I'm not going to be the expert here in figuring out the consistency. That's going to be done when we do a formal swallow evaluation with like a speech language pathologist. They're going to be able to help us figure out that right consistency. But that means I'm going to need to give that right consistency diet to my patient. Now, a lot of times people that have dysphagia can't just swallow thin liquids like my coffee here this morning. We have to thicken them on up. We have special thickeners that can thicken liquids to honey consistency, nectar thick consistency. Absolutely. I love that idea of collaborating with that dietitian. Cut into small pieces. Absolutely. So we're probably going to have to put this patient on a modified diet. Absolutely. Sometimes our speech language pathologist even recommends our patient tucking their chin down a certain way. So it's going to be really important again for us to work with other members of the team. But as the nurses, some important things to remember: we're going to sit upright. We're going to utilize the appropriate texture for our patient, the appropriate consistency, and of course we want to monitor for aspiration. Now, aspiration. So aspirations, when food or fluids go into our trachea instead of down our esophagus. If this happens, if I suspect aspiration pneumonia, what might I see? Well, if my patient starts coughing, if I have them on pulse ox and their pulse ox starts dipping down, if they have sort of a wet, gurgly voice, these may be signs that our patient has aspirated. All right, so got another question here for you, kind of bringing in the idea of hypertension again. I want you to list me 3 dietary modifications that we can do for a patient that has hypertension. What do you guys got for me? What are some things we can do? Ooh, that's a good one, that low sodium. Love that one. Ooh, that DASH diet. Somebody's been studying. Yes, that DASH diet, dietary approach to stopping hypertension. Absolutely. So low sodium. Absolutely. What else we got? Sodium, low. Fat, low. What about some other things? I'm going to give you another hint because I haven't seen it scroll through yet. So this is coffee. What's in my coffee that I shouldn't be drinking too much of it? What's the good stuff in my coffee that I love early in the morning when I'm sleepy and I want to wake up? What do I like? What am I getting from that coffee? That's it, that caffeine. I want to avoid caffeine. Absolutely, caffeine jacks our patient's blood pressure on up. Oopsie, I should probably stop drinking so much. We also want to limit our alcohol intake as well. So dietary modifications, the big ones here, reduce that sodium intake, increase the potassium-rich foods, limit the caffeine, and also limit that alcohol use as well. Awesome. All right here, folks. Let's do another one. What are some signs of dehydration in an elderly patient? And honestly, just what are some signs of dehydration in a patient in general? If we suspect somebody's dehydrated, what are we going to see? Ooh. Absolutely. I'm seeing a lot of answers about skin. You know, I think we forget that our skin is actually an organ, right? It's not one of those big solid organs in our abdomen, but it's still technically an organ. We have to make sure that organ looks good. Are they dry? Is their skin tenting, right? If we gently pinch their skin, does it stay up or does it go back down like my hand just did? So I'm definitely going to look at their skin turgor. Ooh, mucous membranes. Yes, when somebody's dehydrated, they have dry mucous membranes. Their eyes may appear sunken in. Let's see here. What about their mentation? Are they going to be totally with it? Or are we maybe going to see some changes in their level of consciousness, their mentation? What do you guys think? Ooh, headaches, muscle weakness, cramps, that sunken eyes, the changes in their level of consciousness. Yeah, patients oftentimes, especially the elderly get incredibly confused when they are dehydrated, lethargic, absolutely. Now, somebody mentioned vitals. What specific vital sign changes might we see in a patient that's dehydrated? Ooh, urine output less than 30 mils an hour. Love that one. Yes, dark yellow concentrated urine. Ooh, hypotension. Yes. So if somebody's missing volume because they're dehydrated, their blood pressure is going to be lower. So what might go up? Ooh, you got it just as I said it. Their heart rate, that tachycardia. We may see our patient's heart rate start to increase. Awesome. Well done, you guys. You guys are definitely on top of these changes and things we may see in our dehydrated patients. All right, say, what if you're somebody that needs a little bit extra help? What if you're somebody that maybe has taken your NCLEX exam before and were not as successful as you would hope the first time around? Well, I've got another idea for you. So intense prep is really kind of the best of all the worlds of what we have to offer here at Archer Review. So intense prep, it's exactly what it says. It's intense. It's our number one package for the repeat NCLEX test taker. And if you're interested in signing up, guess what? Go ahead and scan that QR code. So intense prep, what is it? So it's a very structured program for 6 weeks that is going to give you a day-by-day plan of what we need you to study. It's also going to have recommendations on questions to do, when to do a readiness assessment, when to do a computer adaptive test, AKA our CATs. Now, besides just that schedule, on Mondays and Wednesdays, you're going to be placed into a small group session. So you're going to work with a tutor, yourself and about 19 other students. It caps off at 20 students per session. You folks are going to be able to go through specific content, and you're also going to receive feedback on how you are doing. So with intense prep, on the schedule, there's going to be days that you need to do questions from the Q Bank. Now, your tutor that is going to be with you on Mondays and Wednesdays, your tutor is going to have access to those scores, which means then your tutor is going to look at those scores and then make recommendations for you. They're going to take notes, say, Betty over here, Betty's not doing so great in cardiac. Then they're going to make you some recommendations on things to do to improve those areas. So I think that's pretty neat right there. I think that's very much worth it, being able to have those small group sessions Monday and Wednesday, Monday, Wednesday, Monday, Wednesday for those 6 weeks. So for a total of 12 sessions. Now, besides just those Monday, Wednesday sessions, you'll also have access to our live reviews. I do live reviews on Tuesdays and Thursdays for 3 hours. We go through systems like the cardiovascular system, the neuro system, respiratory, maternity. We go through all the big ones together. I take you through a slide deck. We do practice questions. We even have another ARCH review hanging out in the chat to answer questions that you may have while I go through the slides. It's a fun time, I promise. You'll have access to the Q Bank, which has now, and I think I even need to update my slide, over 2,900 questions that have both the classic questions and our new NGN type questions. And you'll also have access to our very large ebook. In the ebook, it's going to have all the slides we utilize. It's going to have worksheets, case studies. It's going to have skeleton notes, notes designed for you to test your knowledge. Intense prep starts every 2 weeks. We have our next cohort starting on October 16th, and then another 2 weeks after that on October 30th. If you were interested in intense prep, and because maybe I'm a little biased, I love intense prep, I think you should sign up. I'd love to have you come and hang out with me. Go ahead, scan that QR code and see which session aligns best with you and your time. All right, let's get back to a couple more practice questions while I still have you all here with me here today. All right, so what's the idea behind guided imagery? Why do we do things like guided imagery with our patient? How can it benefit a patient here? I know we mentioned guided imagery before, so when did we mention that here today? Yeah, it's definitely a non-pharmacologic pain management technique. I love it. So it can help with that. What else can it help with besides pain? To calm the mind, absolutely. When patients are hospitalized, when patients are sick, anxiety is a very real problem that plagues our patients. That guided imagery can help us calm our mind. Heck, I use guided imagery when I have a meltdown when I'm taking my certified emergency nurse exam. You can use guided imagery when you're sitting and taking your NCLEX exam to distract our patients. Absolutely, absolutely, you guys. Oh, to lower blood pressure. Ooh, love that idea. Yes, when we calm our entire being down, our blood pressure is going to go down as well. All right, let's see if we can get through a couple more of these questions here together. Let's see here. Let's try this one. Yeah, I want to get us to some positioning questions here. All right. What is the primary goal of using the Trendelenburg position, which is of course where the head of the bed is lowered and then the feet are elevated? Why do we use Trendelenburg? If you have to put a patient in Trendelenburg, what are we probably trying to do here? Ooh, we've got conflicting answers. Oh, let's put it to rest. So we got one person who told me to lower blood pressure. We've got another person to tell me to increase blood pressure. Okay, let's think about it. If our heart, right, our heart's in our chest, we all know that by now. When somebody goes into Trendelenburg position, they go kind of backwards. They kind of go upside down. Why? We're going to use gravity, because gravity always wins. We're going to have gravity help us get that blood back to our heart to promote that venous return back to the heart. Absolutely. So if somebody has a low blood pressure, one of the things we sometimes do, we pop them into Trendelenburg position to return that venous return, to get that blood pressure on up. Absolutely. Now, we also, absolutely, we can use it temporarily to help move around somebody who's pregnant. If we are concerned for a cord, we can move the presenting part on off, absolutely. But I want to just very quickly talk about the idea of that air embolism. There's a very specific position though that we use if we suspect an air embolism. Yes, it's Trendelenburg, but it's a modified version of Trendelenburg, which we call Durant's maneuver. And it's when our patient specifically then lays on their left side in Trendelenburg position, because if we suspect an air embolism, it will trap that air bubble in our patient's right ventricle, because then that right ventricle will be the highest point of the heart. Absolutely. All right, folks, and I've got one more program I want to tell you about before I say farewell to all of you folks here this morning. So we went through the idea of our private tutoring, the one-on-one sessions. We have those small groups that are a little bit cheaper. We have the idea of intense prep, the 6-week very intense program where we walk you through all of those areas that we need to study when we get ready for the NCLEX exam. But we've also got SurePass. Now we have SurePass designed for RNs, we have SurePass designed for our PN folks here. Now the SurePass combo, this is our overall #1 recommended package for all students. Intense prep is really geared towards that repeat test taker, but I promise you, if you're still a first timer, you're gonna get great benefit from intense prep. But SurePass combo, there's none of those small groups, but it is going to include all of our on-demand videos, our QBank, and you're also gonna have access to our next 3-day live review. So folks, here at Archer, at the beginning of every month, so the first Wednesday, Thursday, Friday of the month, myself and many of our other Archer Review tutors, we've got Morgan, we've got Rachel, we've got Kate, we all kind of make guest appearances in this 3-day live review where we take you through all of the systems you need to know for your NCLEX exam. We take you through test taking strategies. We do plenty of practice questions. We do case studies. We have a really good time for 3 days. If you sign up for that SurePass combo, you will get access to next month's 3-day live review. So you'll have access to our on-demand videos for you to excuse me, I haven't had enough coffee here, for you to watch those on-demand videos whenever it fits into your schedule. You'll be able to use all of our Archer Review resources, the QBank. You're gonna have worksheets. You are gonna have a great time. So folks, if you're looking for a little bit extra help and maybe you don't need as much one-on-one help, please scan this QR code and see if SurePass is the right fit for you. All right, folks, well, thank you guys so much for coming and hanging out with me. I can't believe an hour went by already. Thank you for joining us. If you joined from YouTube, if you joined from Facebook, if you were on GoTo here with me, thanks for coming and hanging out with me. I really hope to see you all in one of my live sessions with Intense Prep. Otherwise, happy studying. Good luck on your NCLEX. Take care of yourselves. I'll see you folks later. Bye, everyone.